All right, so the last thing that's important for pharmacokinetics is being able to design and optimize a dosage regimen. This is really kind of like the crux of pharmacokinetics. So whenever you're talking about giving a particular dosage regimen, it's really important because it talks about three particular things. What's the dose of the drug that I'm going to give? What's the dosing interval? So how frequently am I going to be able to give this drug? Is it going to be once a day? Is it going to be twice a day? Is it going to be 3 times a day? And then what's the best route of administration to give this drug? If I'm giving it PO versus if I'm giving it IV. And when we construct a particular type of dosage regimen, we can think about the easiest one. One of the easy ones of being able to accomplish perfect therapeutic concentrations without having to really think and get complicated with respect to the dose, the dosing interval, which route. It's actually really easy whenever you have a continuous infusion, because continuous infusions, the route of administration is IV. The dose that we give, it obviously depends upon what type of effect we're trying to achieve. And then the dosing interval, it's obviously going to be particularly constant. And so when we talk about continuous infusions, what do we kind of see with our graph here? It's really, really cool. So what happens is, when you look at the graph of a continuous infusion, is as you try to increase the concentration of the drug, so it's basically, if I'm putting somebody on a nicardipine infusion for blood pressure, I'm trying to target a particular blood pressure. I want their systolic blood pressure less than 140. So titrate the actual drug, the dosage, per unit time based upon that goal, getting their blood pressure less than 140 millimeters of mercury, systolic. And so what you have to do is you'll start seeing that maybe the patient requires more drug. And you increase the drug concentration over time, and it starts to get to a peak. And once you reach that peak plasma concentration, what you'll notice is that if you stopped giving the drug, right, you just eventually said, okay, turn the infusion off. What would you notice about the concentration? It would eventually start falling off and it would become eliminated. Well, the drug administration and dosing is starting to go up. Guess what else is occurring at the same time as I'm giving this drug? So as this drug is being pushed into the circulation, increasing the concentration of the drug inside of the actual bloodstream, guess what else is happening with the drug? The drug is going to the liver. It's actually being metabolized. It's also going to the kidneys and it's being excreted. So the elimination of the drug is going to start doing what? The elimination is going to start increasing. And then what you'll start seeing is the concentration of the drug decreasing. But whenever you have a patient on a continuous infusion, what you'll notice is you'll get to a perfect point where the dosing of the drug starts to become equivalent to the elimination of the drug. So you get them to a particular concentration of the drug where their dosing rate, so the rate at which you're administering the drug, becomes perfectly equal to their elimination rate. So there's not, basically, it's like an equilibrium. So the amount of drug that's coming in is equal to the amount of drug that's being eliminated from the body. And because of that, what will I notice? I'll notice this kind of plateau, this steady state, if you will, that the concentration of the drugs remain about the same, because my dosing rate, the rate that I'm giving the drug, maybe it's at 15 milligrams, per minute or whatever, and the elimination rate is equal to that. And so I'm eliminating the same amount of drug that's actually coming into the systemic circulation. And that's a beautiful concept, because once we get to this point where the concentration of the drug is kind of staying the same, where the dosing rate is equivalent to the elimination rate, that's a very particular time. You know what this is called? You know what this concentration is where we hit this particular state? This is called your steady state concentration. So it's called your steady state concentration. So the steady state concentration is the concentration at which the dosing rate is equivalent to the elimination rate. Now here's what you may be asked on the exam. What is the time that it takes to be able to get you to steady state concentration? How much time does it take to be able to reach steady state concentration of the drug? Well, this comes back to half-life. And if you guys remember, we said that whenever we're trying to eliminate, so we'll put E for eliminate, when we eliminate, it took 4 to 5 half-lives to be able to eliminate how much of the drug? 95% of the drug. The same thing is to be able to reach steady state concentration, it takes about 4 to 5 half-lives to be able to get it to the concentration inside of the actual bloodstream where it's equal to the amount that's being eliminated. So the time required to reach your steady state concentration is heavily dependent upon the half-life. And the amount of half-lives it takes to be able to reach steady state concentration is about 4 to 5 half-lives. That's what I want you guys to remember. So it takes 4 to 5 half-lives to eliminate 95% of the drug, but it also takes 4 to 5 half-lives to reach a steady state concentration of the drug, which is where the dosing rate is equal to the elimination rate. Boom, roasted. Now, the concentration that we basically approach or reach when we hit steady state, so whenever the dosing rate is equivalent to the elimination rate, has nothing to do with the half-life, the actual drug concentration. I could, let's say, I was at 10 milligrams per minute and I finally reached steady state at 10 milligrams per minute. Let's say I wanted to increase the concentration of the drug because now I want to drop their blood pressure to less than 120. So now I got to increase the concentration of the drug. As I increase the concentration of the drug to like 15 milligrams per minute, eventually what will happen is I'll eventually reach this point where the 15 milligrams per minute that I'm dosing them at will equal the elimination rate. So this will be their new steady state concentration. Their new steady state concentration will be right here. But the time that it takes for them to be able to reach that is still 4 to 5 half-lives. I just increased the concentration by increasing the infusion rate. Same thing. If I wanted to decrease, now I don't want to target less than 120. I want to target less than 160 systolic blood pressure. So I decrease my infusion rate. So it was 10 here, 15 here. I'm going to drop it down to 7.5 milligrams per minute. So by doing that, I'm going to decrease this and I'm going to try to get to a point where my steady state concentration is reached. And eventually it'll kind of look like this. The time it takes for me to reach steady state is still the same, but the concentration at steady state is different. But I'm still at steady state at the same time frame. So the steady state concentration, or the concentration at steady state, is dependent not on the half-life, but on the infusion rate. If I increase the infusion rate, I'll increase the concentration at steady state. If I decrease the infusion rate, I'll decrease the concentration at steady state. But I'll still reach steady state in 4 to 5 half-lives. Whew, I hope that made sense. All right, the next type of dosage regimen that we have to talk about, which is probably one of the most common ones that most people encounter, is maintenance doses and loading doses. Because daily people are taking medications at a particular dosage every specific, 24 hours, 12 hours, 8 hours. And it's important to understand that we sometimes have to modify the dosage based upon renal function and liver function. And so we have to talk about something called maintenance doses and loading doses, and we'll talk about this graph here in a second. All right, so maintenance doses and loading doses. So what is a maintenance dose? Maintenance dose is basically the dose of drug that you want to give a patient that's required to maintain steady state concentration. That's all it is. It's the dose required to maintain steady state concentration, my friends. So how do we actually calculate maintenance dose? If we had to determine really what's the definition of maintenance dose, it really is the dose required to maintain steady state. But we could actually say it's the target plasma concentration. So let's say it's the concentration of the drug in the plasma that you want to target, multiplied by what's called clearance, very important concept here, very important one, multiplied by what's called the dosing interval, which will be represented by this like T. Okay, and then for non-IV drugs, or IV drugs, divided by the bioavailability of the drug, F. If it's IV, it's 1 or 100%, okay? But if it's oral, it may not have 100% bioavailability. You have to determine that based upon the calculations we talked about over there. But that's how we would determine maintenance dose. So it's the concentration that you're trying to target within the plasma, multiplied by the clearance, multiplied by the dosing interval, divided by the bioavailability. And we know it's the dose required to maintain steady state concentration. But what you also need to know is that the concentration of the drug is dependent. It's proportional to the dosing interval. So if you change the dosing interval, for example, if you want to maintain a particular concentration of the drug, let's say that you want to have a particular concentration of the drug, maybe you have the dosing interval to be more frequent and you'll be able to maintain a good concentration. So sometimes if you think about maintenance doses, we could think about like if you give a particular drug, right? Let's say that you give a drug at this time, this time, this time, this time, and this time. So let's say every 8 hours, I'm giving a particular dosage of a drug. When I give that, what will happen is I'll see the concentration of the drug increase, right? It will reach an eventual peak, and then what will happen is after it reaches a peak, its dosing rate will what? we'll start to see that the elimination rate will start to increase. So we'll start metabolizing, excreting the drug, and we'll see the concentration of the drug dip. But then right around that time where the concentration of the drug is decreasing because we're eliminating it, we give another hit of the drug. And then we see the concentration rise. So we get another peak. But then the metabolism of the drug, the excretion of the drug will start to occur, and we'll start to see a dip. But before it hits again the complete elimination of it, we'll give another dose. And then from there, we'll increase the concentration of the drug, and you guys get the point. We'll keep coming down, hit it, keep coming down, hit it. And eventually we'll get to this point, hopefully, where if you were to imagine, let's actually say that it's like right around, let's say that it's like right around here. We get to this point here where we increase it, and then we increase it. And then eventually we start to notice that the rate of drug administration or dosing is going to be equal to the rate of elimination. You see how it's about the exact same? So at this point right here, where we were noticing, if we're obeying first order kinetics, we're seeing that as we increase the concentration of the drug, we're noticing that the rate of elimination, or we're noticing like the rate of metabolism, all of these things are particularly increasing. But eventually we'll start to hit a steady state. Once we hit that steady state, now we're actually at the point where the rate of drug dosing or administration is equal to the drug elimination, the rate. And so at this point is where we're at steady state, and that's about 4 to 5 half-lives, right? So this would be the doses that we're trying to be able to give to get a patient to maintain this point here. This is their steady state concentration. That's going to be about 4 to 5 half-lives to get their steady state concentration, okay? But again, it's important to be able to remember it's that point where the rate of dosing is equal to the rate of elimination of the drug. Now, that's really, really important that we understand this. The other thing that's really important with maintenance doses, besides the dosing interval, because that, again, the dosing interval determines the drug concentration. It's the dose required to maintain steady state, but there's also this other factor here, which is clearance. Clearance has a huge role in maintenance dosing. So for example, if I have a patient who, if you guys remember, the clearance controlled by the renal system, the clearance controlled by the hepatic system, these were the two primary systems that were involved in clearance. If there is dysfunction of the kidneys, the ability to eliminate a drug from the body will decrease. So the clearance will decrease. And then again, the hepatic system, the hepatic dysfunction. So if there's dysfunction of the liver, the ability to metabolize and excrete particular drugs will decrease. So the clearance by the hepatic system will decrease. If clearance is decreasing, what would that effectively need to happen? What would you need to do to the maintenance dose then? Because if you can't clear a drug, what happens to the concentration of that drug? That means that the actual concentration of the drug inside of the actual blood plasma is going to be increased. And if you give if you keep giving high dosages and you aren't able to clear that drug, then the concentration of the drug will be high and you'll start seeing side effects or toxicity. So when clearance is actually diminished in situations like renal dysfunction, hepatic dysfunction, what do you need to do to the maintenance dose? You need to decrease the maintenance dose. So remember, whenever there is decreased clearance, you need to modify your maintenance dose. Another thing that you can do to decrease the actual concentration here is think about this. What if I change my time interval? So if I change my dosing interval, that'll also, since dosing interval and drug concentration are proportional, if I change my dosing interval, that might also be a little bit more helpful. So maybe modify the maintenance dose or change the dosing interval to actually lead to less of the concentration of the drug. So these are important concepts. Whenever clearance is decreased, modify your maintenance dose, change your dosing interval, maybe to be less frequent. And that'll actually lead to less of the actual concentration of the drug. So it's important to remember that. Maybe decrease your your dosing interval and modify or decrease your maintenance dose when a patient has decreased renal and hepatic clearance. All right. The next thing that we have to talk about is maintenance dose. We understand, right? It takes some time, 4 to 5 half-lives, for us to be able to reach steady state. But what if I have a situation where a patient is dying? Okay, they are in status epilepticus, and I don't have 4 to 5 half-lives. I don't have as much time to put them on a maintenance dose of Keppra or fosphenytoin or lacosamide or whatever the drug may be to be able to stop their seizures. I need to reach rapid plasma. I need to rapidly reach serum plasma concentrations that'll actually allow for me to get to steady state quicker. So in order for me to do that, whenever I have a patient who's really, really ill, so let's say I have an ill patient and I want to get that plasma concentration up high really quickly, I give them something called a loading dose. Now, loading doses are basically the target plasma concentration that you're trying to achieve multiplied by the volume of distribution divided by the bioavailability. And this is the important one here, the volume of distribution. But again, the whole point of a loading dose is to rapidly reach a peak or very high serum concentration of a drug so that you can get them to steady state a little bit quicker, hopefully. So it helps us to reach a peak or a peak serum drug concentration rapidly. So it helps us to be able to reach a very high peak serum drug concentration very rapidly in critically ill individuals. So if you can imagine here, look at how much time it took giving these maintenance doses to be able to get us to the peak kind of like serum concentration that we need, that we want to maintain steady state at. If I give this patient a loading dose, so let's actually do this in like this color here. What I'm gonna do is I'm going to hit them really, really quickly with this very large dose. And then from there, we'll be able to give them their maintenance doses to maintain steady state concentration. So whenever I have a patient who's very, very sick, oftentimes we'll give them a loading dose. For example, if I have a patient who's in status epilepticus, I'll give them a heavy dose of a particular antiepileptic. For example, let's say levetiracetam or Keppra, most commonly utilized one. You can give them 3 grams of Keppra. So that's their loading dose. That's going to help them to reach peak serum concentrations of the Keppra to exert its effect. Then after that, maybe a certain hours later, I'll put them on a maintenance dose, which is not as high as a loading dose. Maybe instead of putting them on 3 grams, I'll put them on 1.5 grams, and I'll put it on them twice a day. So it's 1.5 grams twice a day. That's their maintenance dose to maintain the steady state concentration to allow for them to have anti-seizure effects. So that's the significance of loading doses. It helps them to reach peak serum concentrations quickly in critically ill individuals, and maintenance doses helps us to maintain a steady state concentration. The dose is dependent upon the dosing interval. You decrease the dosing interval to be able to help with lowering potentially the drug concentration. And then we also said that maintenance dose is really, really heavily dependent on clearance. If someone has renal dysfunction and a drug is renally cleared, that's going to cause them to accumulate more of that drug. So you need to decrease their maintenance dose or change their dosing interval to be less frequent, okay? If they have hepatic dysfunction, the drug is hepatically cleared, you need to modify, decrease the maintenance dose, and again, change the dosing interval to be less frequent so that you don't have toxic side effects. For loading dose, it's heavily dependent upon volume of distribution. And I know you guys remember this, volume of distribution. If you have a particular volume of distribution, let's say, volume of distribution for this person here, for the loading dose, let's actually do this. Let's say you have a volume of distribution and it's very high versus a volume of distribution and it's really low. So high volume of distribution, what does that mean for the serum concentration of the drug? If a volume of distribution is high, does that mean it's highly distributed? So does that mean that there's much in the plasma? No. So that means that there is decreased plasma concentration of the drug. And then for a low volume of distribution, what does that mean for the plasma concentration of the drug in the serum? It would be very high because it's not very distributed. And so in this case, there will be a very high plasma concentration of the drug. If I want to reach peak serum concentrations, I want to increase my serum concentration in the blood rapidly, which one would I need to give a heavier loading dose for? The one with a high volume of distribution or the one for a low volume of distribution? I would want to give a very heavy loading dose in situations where the volume of distribution is high. So these will require a very high loading dose, and these will require a lower loading dose. So it's very, very important to remember that. So again, loading dose is very importantly related to volume of distribution. If the volume of distribution of that particular drug is very high, you're going to have to give a very, very high loading dose for it to reach peak serum concentrations, because it's going to try to distribute and get out of the vasculature. If you have a drug that has a very low volume of distribution, that means it's already pretty high in the serum and in the blood. So I wouldn't need as high of a loading dose to reach that peak serum concentration. Same thing for maintenance doses. If the clearance is reduced because of hepatic or renal dysfunction, whichever route that the drug is cleared or eliminated from the body, you need to decrease the maintenance dose. Because if there's decreased clearance, you will have the patient retaining too much of the drug and they'll have toxic side effects. Reduce the dose, change the dosing interval to be less frequent. I hope this made sense. All right, guys, let's do some questions on dosage regimen. So we got a 64-year-old female patient, 60 kgs, treated with an experimental drug nerd for type 2 diabetes. Drug nerd is available as tablets with an oral bioavailability of about 90%. If the volume of distribution is 2 liters per kg and the desired steady-state plasma concentration that you want to reach is 3 milligrams per liter, what is the following most appropriate oral loading dose that we should give of drug nerd to treat this patient with type 2 diabetes? So you remember, when we give a loading dose is designed to be able to help us to be able to reach peak plasma concentrations very, very quickly in patients who need it very, very immediately. So it just helps us to be able to get up into that peak concentration very quickly. So when we talked about the loading dose formula, it was actually the target plasma concentration multiplied by the volume of distribution divided by the bioavailability. That's our formula. And we said that the most important component in that is volume of distribution. So we said that for volume of distribution, as we increase the volume of distribution of a drug, that means that less of it is going to end up in the plasma. More of it is distributing into the tissues, into other extravascular compartments. So because of that, not as much of it is going to be in the bloodstream or the plasma. And so the concentration of that drug in the plasma will reduce. And so because of that, we have to give very high loading doses. And with drugs that have high volume of distributions and drugs that have a very low volume of distribution, we can give very low loading doses. But let's go ahead and plug all these things in. It's just a plug and chug. So you have to memorize this formula and know the most important relationship between loading dose is volume of distribution of the drug. That is the most important factor. So if we take that into consideration, we're going to plug 3 milligrams per liter into the target plasma concentration, 2 liters per kg of this drug. So that's not a ton. But we're going to plug that in there into the volume of distribution. And then the bioavailability is 90%. If it was an IV drug, it'd be 100%, so it'd be 1. In this case, it's going to be 0.9. So if we plug all of this in, it's going to be 120 times 3 divided by 0.9. And the only reason we got 120 liters is because we're taking 2 liters per kg and multiplying it by the weight of the patient, which is 60 kgs. Okay, because the volume of distribution should be in liters. All right, so if we take that into consideration, when we do this, what's our loading dose? It's 400 milligrams. So that would be the potential answer here is 400 milligrams. That's how much we would have to give. But again, the most important relationship here that I can't stress enough is that loading dose is extremely dependent upon the volume of distribution of the drug. If this increases, you have to increase the loading dose to get that plasma concentration high. If it's low, you don't have to give as much of a loading dose because the drug is going to be staying in the vascular compartment. So you don't have to give a heavy loading dose. It's a very important relationship here. All right, guys, so in this video, we definitely talked about a lot of things about dosage regimen. I think it's really important. I hope this stuff made sense. And again, don't also forget that when we talk about loading dose, we understand that there's a significant importance to loading dose and volume of distribution. In the same way, there's an extremely important relationship between maintenance dose and clearance. So again, remember your particular formulas for these, because again, if you're asked a question, it's just a plug and chug in these particular formulas. Knowing that formula is extremely important to be able to get any correct answer, but also know the important relationships between loading dose and volume of distribution and maintenance dose and clearance. All right, engineers, hope this made sense. I hope that you guys enjoyed it. And as always, until next time.